heard about this immunotherapy, so-called immunotherapy in advanced stage lung cancer. I said so-called immunotherapy is because immunotherapy is a broad term, and it actually covers different types of immunotherapeutic strategy. One of them is tumor vaccine, but we are not talking about tumor vaccine in treating patients with lung cancer. For indeed, we have been using this new type of drugs called the immune checkpoint inhibitor, which is just one form of modulation of the immune system, so-called one form of immunotherapy for treatment of patients with lung cancer, and we are utilizing this axis this time that we know that there is actually expression of this PD-L1 ligand on tumor cells that can bind with the PD-1 expression on cytotoxic T cells. That means this time is not chemotherapy. And the drug is actually trying to bind or to block the binding of this PD-L1 to PD-1 binding on the different cells. And if we do not block this two receptor binding, the PD-L1 binding, the PD-L1 expression on the tumor cells is supposed to bind with the PD-1 expression on T cells, and such binding is known to send a signal from the tumor cells to the cytotoxic T cells: do not kill me, or go to apoptosis. So that's why in such immunotherapy, if we can use a drug to block such communication, we can try to preserve the cytotoxicity of T cells against tumor, and blocking the tumor cells from hiding themselves away from T cell surveillance. So a lot of the mechanism actually depends on preserving the cytotoxic T cell function with such a drug. And it has been proven to be effective for second-line therapy for patients with advanced stage lung cancer. But mind you, some of the drugs listed here that is available in the market, some of them will bind PD-1 on the T cells, blocking the communication of the PD-L1, PD-1 axis. But some of the drugs will bind to tumor cells for the PD-L1, blocking such communication. So those drugs listed are not necessarily binding the same thing. For the first two, pembrolizumab and nivolumab is anti-PD-1, blocking the T cells, while atezolizumab, the third one, is anti-PD-L1, blocking the PD-L1 on tumor. So it's been proven in the second-line setting that if it can be used, then it will be translated into survival benefits in patients who can tolerate the treatment. Also, in the first-line setting, it has been shown to be efficacious, but do we have the biomarkers? And actually, people has been searching for a biomarkers for this immunotherapy or immune checkpoint inhibitor, and it's been shown that if in the first-line setting, if we can stain, just like ELK, we stain with immunohistochemistry, the PD-L1 expression on the tumor, with a tumor proportional score of more than 50% by immunohistochemistry, then it will be translated into a survival benefits for the patient. And this is what we call the tumor proportional score. Very complicated, and is not only counting on the number of cells that express PD-L1 in the tumor, but also counting the intensity of the expression in different cells in a tumor. So what we call the tumor proportional score. But it is not perfect yet, and people is now exploring whether there is a better score called the composite proportional score that also takes into account not only the PD-L1 expression on the tumor cells, but also counting the PD-1 expression in the tumor-infiltrating lymphocytes. So, as I said, both the biomarkers, and although it's been translated into survival benefit, the biomarkers is not good enough for stratifying the response or the efficacy of the tumors yet. Immune inhibitor, this immune checkpoint inhibitor is associated with a different set of adverse effects compared to conventional chemotherapy or even targeted therapy. And the most common one is indeed disturbance to the hypothalamic pituitary axis. And the most common one of disturbance is indeed disturbance to the hypothalamic thyroid axis. And usually patients could present with hypothyroidism or hyperthyroidism, with hypothyroidism more common than the hyperthyroidism. Even if there is no disturbance to the thyroid axis, the patients receiving these immune checkpoint inhibitor, the most common adverse effects is indeed general malaise. So it will be aggravated with the disturbance of the hypothalamic, pituitary, and thyroid axis if it is got disturbed. So in the patients who have received this immune checkpoint inhibitor, sometimes they will complain of a general malaise, and it is also a routine for us to check the relevant endocrine function, especially the thyroid function for the patients, in order to detect whether the patient is actually having disturbance with the thyroid axis. And we are pulmonologists, so a lot of the times we are faced with patients who present with the immune-mediated adverse reaction, the pneumonitis, which could be quite severe, but at the same time, it could be manageable with management with high-dose systemic steroid. So it's a manageable side effects. And a lot of the times is mild grade of adverse effects, general malaise that is manageable, but do on follow-up for these patients to detect if there is any presence of pneumonitis, which could be severe. The biomarkers is not perfect yet, and it's very confusing in the literature that different companies actually develop different kinds of antibodies for detection of these PD-L1 expression. And unfortunately, a lot of these studies actually were derived from the Caucasian population. And as mentioned, we have a lot of patients with EGFR mutation and non-oncogenic driver mutation. And it has been shown that patients with the oncogenic driver mutations in their tumors actually is doing not that good for with the immune checkpoint inhibitor. So we do not know the exact mechanism yet, but we believe that it may somehow tie with the original nature of those tumors that bear the oncogenic driver mutation. For example, whether it could be related to the tumor mutation burden of the tumor. And it has been known that patients who are usually having tumors with adenocarcinoma, a lot of the times is non-smokers. And also, we have those patients with EGFR mutation. These patients are known to have a lesser mutation burden if we take the various different kinds of mutations in the tumor genome as a whole. And we do not know if this is the only mechanism, the tumor mutation, the total tumor mutation burden of the tumor. And there are also in vitro experiments that have shown that patients with PD-L1 expression in the tumor, for those tumors that express PD-L1, sometimes the expression is quite dynamic. That when you try to attack the tumor with that drug for blocking the PD-L1 and PD-1 combination, sometimes, somehow, tumor cells has been shown to have this dynamic expression in that they will reduce the expression of PD-L1 on exposure to the drugs, thus making the drug less sensitive, especially in patients with EGFR mutation. But such mechanisms has to be confirmed further, and in our laboratory, we have tried to recapitulate the phenomenon of this binding of these cancer cells together with T cells with a co-culture. It was